Bismillah ar-Rahman ar-Rahim. It's always great to do these seminars, and I think when you're looking at the actual cases, you'll realize that we're doing a very detailed assessment of each patient. Every word, as was pointed out earlier, every word counts. So these are not tricks. These are actually really important patients in which there's embedded clinical concepts, things we've seen, inertia, things where we've seen incorrect management. So we're just trying to highlight this because, again, this is a very important approach where we have a circular, complete approach to the whole patient, right? So every complication has an impact, not just on that, like the one with the eye, for example. It's not just the eye we're concerned about. This means that the patient has cardiovascular disease and therefore needs intensification of lipid-lowering therapy and the blood pressure. So all of these elements are important. All of you are seeing patients with diabetes and prediabetes. And when you are looking at that patient, remember this is a patient who is already at amplified risk. Patients with diabetes lose at least 6 to 12 years of their life compared to people without diabetes. So you're looking at a high-risk patient. Even though it's very common, you really have to apply some, shall I say, intensive care mentality when you're looking at the patients. You guys good? 1 more minute? Okay, so I'll keep talking while we do it. So one of the things we wanted to highlight is that every wave we're doing something different. So last wave we were focused more on atherosclerotic cardiovascular disease and obesity as an impact. This wave we're looking at dyslipidemia and other organ disease, liver abnormalities, fatty liver, hypertension, retinopathy. So each one will have a slightly different flavor. So please tell your friends and come to the next one. The next one is not going to be the same either. So I think we're going to have something about the kidney and the heart. So it is a complementary process. We can't cover everything in the 4 cases we do, but every time we're doing it, we're doing something new. We're also learning from you and your insights as well. Some of the questions that you're asking are triggering us to make some changes on the actual format of the program. So the reason why I'm talking for 3 minutes is that I've made a small change in the slides. I was inspired by Dr. Khadija's presentation, so that's why they're uploading it again. All right. So just to get an idea, who here are, any cardiologists in the room? Cardiologists? No? Okay then. No, then I can make things up as I go, right? And any nephrologists? Anyone? Last time we had a nephrologist? Yeah. How about internal medicine and family medicine? All right. Okay. Endocrinology and diabetes? Excellent. Of course. Faculties exempted. And any other specialties? Anyone? All right. So as we know, we have to scan the QR code. This is actually, I think, a very important part of the discussion is the answers you provide, right? Think about it as like a deep dive or a master class or a workshop, but I think the interactions we get here are a lot more intense than the typical workshops that I've seen before. And the faculty has done a tremendous job of actually detailing these cases and looking for all of these little teaching points. So please scan the QR code so that you can be in the polling. This is very important. So, a 54-year-old female alarmed by a recent cardiovascular event in her family. So this Mona, 54-year-old, she's a banker. She's not a smoker. She's just a lot of stress, busy schedule. She occasionally exercises. So this is a trick question. When you tell people, do you exercise? Yes. When's the last time? 3 months ago. That doesn't count. The definition of exercise for health, do you know what the number is? It's typically 150 minutes per week. So that's 3 times 30 minutes, or 5 days a week. It has to be consistent, and that's the key point. Now, walking in the mall also doesn't count as exercise. You basically have to increase your heart rate by at least 20% consistently for at least 20 minutes for that to count as exercise in terms of insulin resistance. Now, you don't have to run. You can always do resistance training or endurance training. Anything works, but as long as it's done consistently. And that's really the problem that doesn't happen. So she was recently diagnosed with diabetes a year back. She's had hypertension for 3 years. She has a family history of MI. Her current HbA1c is 6.6. So the reason why she came to the clinic, because her sister, who is 51, suffered a heart attack 1 week back. Okay? So if you remember when we talk about the definition of family history of premature cardiovascular disease, what is that defined as? What are the age cutoff points? Female less than 65, male less than 55. So remember that. And that's from European literature, and maybe more here, because we have a lot of premature cardiovascular disease. So if you look at the average days, the average literature for patients with MI, what's the average age for myocardial infarction in the Gulf? 49, right? So by definition, we're already less than the premature ASCVD cutoff that the Europeans are telling us, right? The average, that's the mean. That's 50% of people are having an MI less than the age of 49, right? So that number may have to be advised or adjusted for the Middle East, but that's what we have. So clearly this woman's sister has premature ASCVD. What is the implication of that in this patient? What does it mean? Family history is a powerful risk enhancer, especially in females. Remember this, right? It's very unusual to see a woman of this age have a myocardial infarction. So it should trigger a lot of thinking. And that means that the family has to be screened in a different mindset. You have to think about that risk as a very high red flag. There's no specific number we can add to it, but I think you have to get that clue. And the other thing is if the patient doesn't elicit it, you have to ask the question, right? When we ask a general question, does anyone in your family have heart problems? La, tamam. Okay? Then ask a specific question. Anyone in your family recently had a heart attack? Placed a stent, had a bypass. Oh yeah, my uncle had a stent. My father had a... So you have to ask specific questions because the general health literature isn't very clear, right? People don't really know how to answer these questions. There's not a lot of stuff on how you, the patients don't really know that link. So what's her medication right now? Amlodipine 5, a thiazide-like diuretic 5 milligrams, metformin, and gliclazide. Are we happy with this regimen? Do you need more information? What other things do we need to do? Okay, so I'll give you some more information. So her weight is 86, her height's 164, BMI is 32, and her in-office blood pressure is 128/75. She's currently not reporting chest pain or shortness of breath. She's just here because her sister, now she's in a panic. This is an opportunity, actually, to revise the whole syndrome and look at the patient more carefully, because now the patient is motivated. So remember, the motivation of the patient is, we don't talk about this a lot, but I think it's important to see what's in it for the patient. So how do you classify this patient's, is this patient healthy, obese, markedly obese? What's the class? 2? Abdurrahman? 1 or 2? Fair. And do you think that the BMI is the only determinant of obesity? So there's a little bit of a disconnect here. Sometimes we're talking about waist circumference. So remember what we're trying to think about. What is the unhealthy problem here is that the visceral obesity, which is resultant in insulin resistance. So think about that. If you get somebody who's bulky, a lot of muscle, right? The BMI may not reflect the actual problem. But this is not an issue we see a lot here. Most of the patients we have a classical linked BMI and waist circumference, right? This seems to be important in patients of Asian descent because the waist circumference that's described and the BMI that's described, the cutoff points are not really appropriate in patients from Southeast Asia. So 26 may be high for a patient from Southeast Asia. So remember, these numbers are coming from European literature. So always look at your patient individually. So the patient is not having any symptoms at this point, okay? So we've oops, we appear to be offline. What? Okay. Is that right? Okay. So I think the next one is an audience response, right? So what are the other tests that you do now? I mean, so this is an opportunistic visit. The patient has been motivated by a family history event. There's a lot of risk that you see just from this description. So obesity is a significant, important risk factor. You have family history. The patient's on treatment for hypertension, does not appear to be on any treatment for dyslipidemia, and she's diabetic, right? So let's see. So fine, we have the audience response. If you can just scan the QR code to get into the polling. So the primary factors that prompt you to recommend screening. So a family history, an elevated BMI, a history of diabetes, certain lifestyle factors being sedentary, high blood pressure, age, and gender. So if you remember from the guidelines, Professor Hassanein and Dr. showed the who to screen, right? Who to screen actually is everybody, isn't it? Anybody with pre-diabetes or diabetes. But how do you know if they have diabetes or pre-diabetes, right? So there's another layer of screening. Do you know that they have a dysglycemia or not? But these are also high-risk patients. So 19 of you answered. So a family history of cardiovascular disease is significant, right? This is a different kind of patient than the patient who walks in and has no family history. There's clearly something. And I would like to add the word premature cardiovascular disease, right? So if somebody has had, the father has had an MI at the age of 82, that's probably expected. It's not premature. But the more premature the problem is, the more you have to be attentive. It's a red flag. It's not well described in the guidelines, I'll tell you this. But it is something that you know as an individual phenotype is very important. Now, the elevated BMI, the history of diabetes, that makes it mandatory, right? Patients with hypertension. So the Emirates Diabetes Association guidelines are about screening for diabetes in the population, right? So that's something important because we have a very high number of patients with metabolic syndrome. It's around 30%, about a third of the population. So you have to look for diabetes in these patients as well, and that means HbA1c. Lifestyle and obesity are linked together. There's no specific thing about age and gender except what we talked about premature, right? The cutoff points are 65 and 55. So, who to screen? Pre-diabetes, type 2 diabetes, and adults with type 10 diabetes more than 10 years duration. As was pointed out previously, you don't know when that diagnosis was made. It is now maybe possible using electronic medical records. Some of the EMRs do go back a few years, but this number is often difficult to determine. And sometimes in the type 1 diabetic, it's more dramatic because that's the date that they got into the hospital, they had DKA, and they were started on insulin. The type 2 diabetes is sort of a slow sliding start. It's not always consistent. So, the medical history. So the patient just tells you, I don't have chest pain. Is that sufficient? You have to actually elicit symptoms of cardiovascular disease. What are the symptoms of cardiovascular disease? Not just chest pain. What's another symptom? Shortness of breath, right? So that could be a sign of fatigue, sleep apnea, overweight, or it could be a sign of heart failure. Exertional shortness of breath is very important, right? Next is palpitations. Atrial fibrillation is another cardiovascular disease. So it's not only angina, it's not only, heart failure, it's also arrhythmia. So think about those things and in that context. Ask for these. Do you ever have irregular heartbeat and palpitations? Maybe atrial fibrillation is happening, right? It's common. 40% of patients with obesity and sleep apnea have atrial fibrillation. So it's a big number. Claudication is very important. As Professor Hassanein pointed out, sedentary patients will neither have exertional shortness of breath, neither claudication. Why? Because they don't walk, right? So you specifically have to ask them, the last time you walked up the stairs or you were in the market, what's the problem? Well, I don't walk. Why don't you walk? Because of this and that. So you have to go back and prompt with a question. Smoking is key. Full examination. Peripheral pulses, including ABI. Now, some of us will find that this is a challenge. It's really not. Most of the patients actually are wearing sandals, right? You know, where we used to work in the US, a lot of patients would be wearing boots because of the snow. Sandals means you can look at the pulse. And make it a standard that before the patient comes into you in the nursing station, an ABI is done. Do it. It's in the guidelines. It's strongly recommended in patients with diabetes, patients with atherosclerosis, patients who smoke. It's practically a give me because it's a simple test. All you're doing is checking the blood pressure in the foot and the arm, and you're done. Very easy. So retinal examination is a must. Now, we have talked about ECG and NT-proBNP for two reasons. ECG shows you if the patient may have abnormal ECG in some way, left axis deviation, left ventricular hypertrophy, some sort of arrhythmia, right? NT-proBNP predicts cardiovascular events. It's not only to detect heart failure. If you have a high NT-proBNP, your likelihood of having a myocardial infarction or a heart attack or a cardiac event is almost 4 times higher in the next year. So it's a very powerful test, and it's been endorsed even by, I heard yesterday that the Department of Health in Abu Dhabi has also endorsed it in their diabetes guidelines, and also DHA as well. These are essential tests: serum creatinine, GFR, and urine albumin-creatinine ratio, to detect a renal disease. If a patient has renal disorder and diabetes, what does that put them? Very high risk. They already have target organ damage, right? So the target organ damage means that you don't have to screen anymore. You have to give them the whole picture of treatment, plus a lipid profile and a CBC, and of course the HbA1c. So looking at this, again, if you want to do the audience response, just the scan here. So what are the things that you're going to do? Fasting blood glucose. Should you do a sleep study for sleep apnea because of the elevated BMI, the fact she doesn't exercise? Kidney function. Should we do a stress test? Ankle brachial index, fundus exam, or NT-proBNP. So the metabolic test, let's keep going. There's only 4 people here. So the essential tests are mentioned in the guidelines as things that you would do annually in a patient with diabetes or high risk, and every other year if you have a patient with lower risk or a patient with prediabetes. But you got to do them at least once at baseline, because they will determine for you something's going on. So if you look at the metabolic component, fasting blood glucose and HbA1c can differentiate between the glycemic status. If your HbA1c is above 6.4, then you're fulfilling the metabolic definition of diabetes. 5.7 to 6.4 puts you in prediabetes. What about a number where the fasting blood glucose is high and the A1c is not? What is that? Is that normal? It's not. It's a state that is just before and maybe related to insulin resistance. There's a little bit difference between impaired fasting glucose and what's the other one? But it's telling you that the patient is heading in that pathway. Remember, it's a process of insulin resistance, and lipid profile is essential, right? We see a lot of patients who don't have a lipid profile, and you wonder why that's happening, right? In a population where 30% are metabolic syndrome, prediabetes and diabetes, the most important determinant of risk actually is the lipid, right? If you have a 1 millimole per liter increase of your LDL, increases your cardiovascular risk by what? 22%. Myocardial infarction or stroke within the next 5 years. It's the most simple to assess and the easiest relationship that we have in medicine. It's a linear relationship. The more you go down, the less the risk. Kidney function is obvious. Do we need to do a stress test on this patient? No, she's not symptomatic. If the ECG is normal and the NT-proBNP is normal, you've basically covered the cardiovascular system. Some references suggest doing a troponin in the outpatient setting. Still controversial, but again, this is cardiovascular risk, not going for ischemia, not going for a cardiac cath, right? Fundus examination, again, is important because, as we saw from the first case, early disease suggests that now the patient has target organ damage. And maybe the patient's HbA1c was done a couple of years ago, but she had diabetes for a longer time. It was just not detected by testing, right? So the duration of diabetes is a little bit of a difficult one to manage because you don't know exactly where the patient sits. Now, ABI, as I mentioned, if the ABI is abnormal, what does that make the patient? Atherosclerotic peripheral vascular disease. That means they are very high risk. Done, right? No more, calculation is needed. So these are really important bedside tests that tell you something wrong. What if the ECG shows LVH? Established cardiovascular disease, target organ damage. Khalas, right? Elevated BNP. So any one of these top 5 items means the patient has either a complication of the diabetes and established disease and now falls into very high risk, and the very high risk has 5 interventions that you need to do. So this is what we have for this patient. Total cholesterol 250, LDL 163, triglycerides 156, and a low HDL. So this is the classical metabolic atherogenic dyslipidemia. CRP is, and this is an optional test. I do it as a cardiologist. You don't specifically have to. It's a risk enhancer. HbA1c 6.6, creatinine is 0.9. ECG is completely normal. Okay? There's no changes. So any comments about this? This is focusing a little bit on the lipids and the A1C. What do we have? Are we happy with this LDL? Okay. So the question is, what LDL do you want to reach in this patient? Right. So you want to first start with your risk. Before you talk to the patient about any number or any treatment, please be certain about the risk. This is a very important concept because that's what's going to tell you, but doctor, the other doctor before you said 163 is fine, just lose some weight. So how do you convince them that now they have to radically change? You have to tell them the lower target is related to cardiovascular risk, right? So remember the ABI. Please, if you're not doing it, it's a very simple test. You know, your nurse can literally do it while the patient's waiting outside getting their blood pressure. So you put the blood pressure cuff up here in the arm, and you put another blood pressure cuff in both legs, right? Always, you see the difference. It's very simple. You're just looking at the systolic pressure, actually, not even looking at the diastolic. That's the only number you're getting. And you just do the ratio. So arm over leg. Should the leg have more blood flow than the arm? Yes. It's twice the size, and it's a bigger organ. It's a bigger limb. So if it's less than 1.0, it's abnormal. Simple. Very easy. This is not a technical test. It's not an ultrasound. It's not a Doppler. It's simply a blood pressure reading. And you can literally tell the patient, this means there is a blockage between the arms and the legs, usually in the aorta or the iliac vessels. That's it. And then you can start that discussion about peripheral artery disease and atherosclerosis and the complications of that, which the patient will be very frightened of, including amputation. Now, even if it's 0.9, it's significant, right? Because the leg should have a much larger artery. The femoral artery is twice the size of the brachial artery, isn't it? So there's something significant when it's less than 1. Now, what if it's calcified? What if the vessels are calcified? A hardened vessel cannot be compressed, so the number goes up. It becomes 1.4, 1.5, see? So you're now going to detect atherosclerosis in both directions. Calcified hardened vessels from hypertension or obstruction due to plaque. All right. Now, I mentioned the signs and symptoms just to highlight this point here. Chest pain is important, edema, often attributed to what? When a patient comes to your clinic in primary care settings, what's the commonest cause that people talk about edema? Amlodipine. Huh? Right? No, heart failure. Think about that. Right? Don't automatically say the edema is from an amlodipine. Think about heart failure. It's certainly possible. You have a BNP that's abnormal, it's going to tell you the patient has heart failure, right? So palpitations, dizziness, fatigue, effort intolerance. People who tell you, I cannot go up the stairs. Why can you not go up the stairs? No. Anybody can go up one flight of stairs. If they can't, they're avoiding it. Avoiding means there's a physical symptoms that they don't like, either claudication or shortness of breath. Think about these points when you're asking the patients. This is a high-risk population. So this is the standard assessment in most diabetics. This is our additional points. They, of course, includes all of this, but also we have these additional findings, NT-proBNP. Now, we added the calcium score. It's a plus-minus test, usually seen by specialists and cardiologists. If a patient doesn't want to take a statin, you do a calcium score, and they see dots of calcium in their arteries. It's very convincing, right? And this is without contrast. Remember, a calcium score is the CT without contrast. So you can literally do it with no risk to the patient. Doesn't matter what their kidney function is, you just do it. It's helpful to convince patients of their cardiovascular risk. Okay. Where are we at? Next one. Okay. So based on the details we just reviewed, what is the patient's current cardiovascular risk category? Low risk, moderate risk, high risk, very high risk. So remember, assessing the risk carefully and putting the patient in the highest possible category of risk is very important, right? Because that allows you to treat them in a more intensive manner, and your targets are numerically lower, right? So, more people vote, please. It's very beneficial to us to see how your responses are, because it also allows us to tailor the program if there are some things that are not entirely clear. So we're getting a little bit of a split here. Very high risk and high risk. So, right? That's it? Everybody done? Would anyone like to tell me why you voted for very high risk, and somebody to tell me why it's high risk? This is really a real discussion. I think we have to be very clear on the risk stratification. Abdurrahman, you know? Yeah.
I voted for very high risk because of the premature infancy. She had a sister who had I think an MI at the age of a heart attack at the age of 51. So that puts her in the very high risk strategy. So we have to target our measurements, LDL, HbA1c according to the certain criteria.
Right. Anyone vote for high risk? If you'd like to. About 10 of you voted for high risk. So one of, no? All right, so let's go into this a little bit more. I think that's helpful. So one of the things you can't forget, I know we have a scoring system, I know we have a calculator, I know we have a lot of things, but remember, this actually has been in the American Heart Association and ACC for a long time. This is the page that nobody looks at. It's a long, annoying table. And the European Society of Cardiology in the hypertension guidelines has also mentioned this high-risk enhancers. These are important, and they're valuable to think about. So persistently elevated LDL more than 160. Okay? That's important. This is a very high number for a young woman, right? It suggests some sort of primary dyslipidemia. Think about that. So she's had it for a long time. Nobody's treated her for a long time. That's probably her baseline. Yeah? Now, chronic kidney disease with albuminuria, right? So CKD is a cardiovascular marker. As we said, that automatically makes the patient very high risk. Yeah? The presence of metabolic syndrome is itself a risk enhancer. Yeah? Now, what about in women? Specific conditions in women, preeclampsia, premature menopause, and polycystic ovary disease. This reflects directly into the risk of hyperlipidemia. Because polycystic ovary, as well, is one of the markers of insulin resistance, right? Isn't it? So think about this patient in a global manner. Inflammatory disease, so patient with rheumatoid arthritis, psoriasis, lupus, HIV, chronic inflammation, chronic hepatitis C. These patients have very elevated inflammation. Inflammation itself leads to atherosclerosis, doesn't it? Right? Okay. Now, this is very important because this group is in our majority of our population, South Asian ancestry. I didn't mention the ancestry in this patient, but rank of South Asian ancestry has increased risk. This was seen in the UK. It's in the UK risk score, in the American risk score. It was seen in the UK PDS. As a matter of fact, in the UK, the Q-Risk engine looks at ethnicity as well as a very important risk factor. So now you're individualizing your treatment decision based on the risk. Now, triglycerides, elevated triglycerides more than 175 or 2.0, persistently elevated. So you have two lipid-related that are very important. Now, if you measure the CRP over 2.0, right? So this one is normal. Having a high lipoprotein A, and the cutoff point has been changed now. It's actually going to be 30, and high ApoB and an ankle brachial index less than 0.9. So these are sort of very important things to do in each patient for lipid management from the first start. Okay? Now, in diabetic patients, you have all of this plus the presence of an ABI 0.9, long duration of diabetes, retinopathy, or neuropathy. These impact your lipid treatment. Why? Because if you have target organ damage, you're very high risk and your LDL target is lower. Does that make sense? If you have any of these risk enhancers, you also are at an increased risk and you become a very high risk patient. You see that? So careful assessment of risk is a scientific approach that makes you do a very detailed risk assessment, treatment decision, and a more aggressive target is needed. So now, Professor Hassanein mentioned this. I'm going to say it again. If the patient has any positive organ damage or positive biomarker, they are very high risk. No calculation. Don't do this. Just go to very high risk, the top line on the table, the red line. Now, if no target organ damage, normal biomarker, this is what we call screen negative. So you've done the physical tests and your physical examination, apply the score. So let's apply the score in this patient. Okay? So she's diabetic, right? Okay. She's over 40, she gets 1. Duration of diabetes, it says 3. But we don't know, it could be longer. So we don't know that. How many risk factors does she have? Hypertensive? obese, dyslipidemic. There's 3. Now, we realized something in our calculator is that even if you have 3, you can't get more than 2 points here, right? So if you take this risk calculator, she's got 1. We don't know about this one, so we're going to have 0, and we're going to have 2. So 1 and 2 makes 3, which puts her at high risk. High risk from what? From the calculator. But you already have 2 additional items that you already know are problematic, right? She has a very high LDL that hasn't been treated for many years. That's this one, right? She has a family history of premature ASCVD. So I would add a point from me, knowing this physical history of the patient, and I would say she's very high risk, right? But strictly speaking, if you take this only, without any other additional risk enhancement. Remember, lipids has risk enhancement built into it. This is something that's been in the science for a long time. It's not related to the diabetes. It's related to the lipids. This is going to be 3 and puts her at high risk. At least high risk. I would say at least high risk, right? So, is that easy? Does everyone understand how we work through this, right? Now, and I think maybe as a steering committee, we're going to have to think about multiple risk factors and maybe give it a 2 or 3, depending on, right? Because this is something we've developed and we're working on it. So cardiovascular risk in diabetes is known to you. This is the factor that's driven by LDL. There's also hepatic production of C-reactive protein. There's reduction of the increased fibrinogen, increased CRP, increased PI1. There's more thrombosis. There's glycated proteins. There's also hypertension. There's also hyperinsulinemia. There's also insulin resistance and high free fatty acids. So the diabetic patient is not just a patient with high glucose, right? Please don't think like that, right? It's a patient with all of these really impaired cross-related metabolic factors, plus they also have hypertension at the background, and they have dyslipidemia, right? So it's 4 or 5 diseases in one. It's a syndrome. It's not just elevated sugar. So we have gone way beyond this old approach, and now that's why we have a committee that consists of cardiologists and endocrinologists and diabetologists and nephrologists and internal medicine. So these are all of the things that you can do and measure in a patient to follow up on those pathways. So you have your renal and microalbuminuria. You have the heart failure and myocardial injury. So that's the proBNP, myocardial damage from troponin, CRP, which is inflammation. You have neurohormonal activation, which you can attack with RAS blockers. You can do an echo or some imaging, and you can see remodeling. Obviously, the blood glucose is central to this. There's blood pressure changes, and the ECG, of course, gives you a lot of information. So this is the syndrome, and there are so many parts that you have to tackle. So in this patient, now we're going to focus on the lipids. We'll go back to the other elements now. What's the primary goal of therapy? Please answer this. It's very important. Getting an LDL reduction by more than 50%. Improving the HDL levels. Reducing triglycerides. Controlling cholesterol. Or reducing cardiovascular risk by lowering both LDL less than 70 and LDL by more than 50%. So you have a dual target, okay? So does anyone believe that our target is to improve HDL? So there's many studies that have shown that a high HDL is protective, right? Observational studies. Interventional studies have failed to do this. Almost a decade worth of medications that increased HDL didn't do anything at all in terms of cardiovascular outcome. The last one, HPS Thrive, had a 7% reduction, but it's only because that medication also lowered the LDL. So it's not about the HDL, unfortunately. I think all of you got this idea. Some of you are still outliers. Triglycerides are important to reduce after you have reduced your LDL. So the primary and secondary and tertiary risk is driven by LDL. And when the patient comes and tells you, الدهون الثلاثية, forget about it. First, I'll get your LDL down to target. Then I'm going to talk about the triglycerides, right? This is an order of magnitude difference in the way we're thinking. Patients are still talking about stuff in the social media, which is completely wrong, okay? So why do we need a dual target? Why is this one? Okay, this one is partially correct. So you're reducing your LDL by 50% is part of the equation. But what if the patient like this has an LDL of 163? What's half of 163? 80. So you've reduced it by 50%, but you're not at the target, right? So the numerical target is as important as the 50% reduction, if not more. So it's been shown. Why does this come? An LDL of less than 55 in the interventional studies was seen in the first IMPROVE-IT study. And those patients had a 31% less cardiovascular event over 7 years, right? So that small difference between 70 and 55 equaled 30%. And in diabetic patients, the absolute risk reduction was almost a full 3%. This is really strong. So you can't really accept a higher number. And that's why defining the target at the beginning means you're going to reach a lower number. And you're going to force the number down using pharmacotherapy and lifestyle intervention. So this is very important. So remember the guidelines. I'm going to show you the next page. You'll see it very clearly. So this is the ESC guideline, which we've been using. It's actually the source of most of the information in our CM guideline. A 50% reduction from baseline, that's the minimum, and 1.8 if you're high risk, 1.4 or 55 if you're very high risk. Okay? Now, I'm showing you this table for a reason. There are many ways that you can look at the patient's risk. So a patient with diabetes and target organ damage was classified in the ESC guideline as very high risk from a lipid standpoint. A patient with diabetes and 3 major risk factors is actually very high risk, right? So this is where there's a little bit of a disagreement between our assessment and the ESC lipid guidelines. I'm just trying to be very precise here. So in this case, again, you're going to look at the patient as an individual and think of what's the best option for this patient. So we need to achieve LDL targets in high and very high risk patients. Just to make it very simple, right? The majority of patients you're going to see are going to be high or very high risk, okay? Some of them will be low risk, fantastic. Follow them carefully. High risk, 1.8, 70 milligrams per deciliter. Very high risk, 1.4 and 55 milligrams per deciliter, okay? So let's proceed. What is a 50% reduction? How do you get a 50% reduction? It has to be a high intensity statin. So look at this list here. Is this high intensity? No. What is the commonly utilized dose of statin in this country? Atorvastatin 10 or 20. Is this high intensity statin? It is not high intensity. It is moderate. In the studies, and this is very clear, a high intensity statin is atorvastatin 40 or 80, rosuvastatin 20 or 40. Okay? Those were defined based on the reduction. The average LDL reduction with these two is 50%. Good? So why do people not use this and use that? Concern about side effects. Are side effects with statins dose dependent? They are absolutely not. They are completely idiosyncratic, right? You can give a patient 5 milligrams of Crestor and they'll have muscle pain. You can give them 40 milligrams of rosuvastatin and they don't. It's idiosyncratic. It's not dose dependent. It's often exaggerated because of things that you see in the social media. Vitamin D deficiency. Don't titrate statins. I'm going to tell you one more thing in the guidelines. There is no such thing as up titration. You don't start with 5, then go to 10, then go to 20. It's not there. There is no clinical study that supports it. All of the studies were either high dose, low dose, or high dose placebo, right? So just go for the test, go for the number that you need to get, and get it done quickly, right? So just to remember this, the principle is lower is better, and also earlier and better. Why earlier? Because in all of the interventional studies, except the MI patients, had a recurrent event rate within the first 6 months. So if you start with 10 milligrams of atorvastatin, wait for 6 months, then the patient's going to have another event. So please remember, time is of essence here. It's a real phenomenon, and we really see a lot of patients who are not properly dosed. Okay? So let's proceed. This is actually from the LDL guidelines. Just to tell you this, high intensity statin equals 50%. So this is the minimum, right? These two. At these doses, 40-80 of atorvastatin, 20-40 of rosuvastatin. Okay? Now, what happens when you add ezetimibe? 65%. What happens when you add PCSK9, statin, and ezetimibe? 85%. So that's the key point. You have to predict in advance. So what I'm trying to tell you is, why don't I titrate? Because I'm going to predict in advance what's the number, right? I know this patient's LDL is 163, okay? Let's say we're going to say she's a very high-risk patient. Humor me for that. I'll say the target's 1.4, 55. So what's that percentage? What is it? So it's 160, multiply by 65%. That gives you, you have to do the math. This is what we do in the clinic. This is the correct way of approaching the patient. Predict the number and see where you fall in terms of the treatment algorithm, right? So multiply 65% and give me the number from 163. So you'll see that you're not going to achieve that with a high-intensity statin, clearly, right? You're not. So if the patient is a high-risk patient, so now your target is 70, right? So 163 to 70. 50% of that, it's still 83%. Add the ezetimibe, what are you going to get? You're going to get 70. Does that make sense? Predict and don't experiment. Give the treatment, send the patient home, then recheck in 4 to 6 weeks or wherever your protocol is. That's how you're supposed to do it. This is what the guidelines been telling us for a long time, right? This is what you have to do. You have to know your baseline LDL and multiply by the percentage predicted, and that's what you're going to do. That's the prescription the patient leaves home with today. All right? So there's other things that you can do in terms of lipids. So a third of these patients have atherogenic dyslipidemia. So I'm not ignoring the HDL, but I'm going to tell you what we have to do next. So if you have injectable lipid-lowering therapies, you can get up to 85% lowering using inclisiran, PCSK9 combined with statin ezetimibe, and therefore there's a proportionate event reduction. So if you have a patient who has had 3 cardiovascular events, you want to lower their LDL even further, right? And addition of icosapent ethyl. The only treatment that is now approved for cardiovascular risk reduction and triglyceride reduction is icosapent ethyl. It is unfortunately not the over-the-counter fish oil. There's no indication for those, right? This one actually reduced cardiovascular risk by 24% in patients with diabetes if they have elevated triglycerides or ASCVD, okay? Now, combination maximum statin, ezetimibe, and PCSK9 in very high-risk patients to achieve 85% reduction of LDL and less than 1.4. It's a linear process, right? So you think about how you want to lower the risk, you have to lower the LDL. So now we're going to go a little bit back to other factors, right? It's the same patient. You're going to address a lot of things. How are you going to do this in 15 minutes in a busy clinic? The answer is you have to, or you have to tell them to come back in a month. You've got to fix all of these items in order to have this circular approach to the patient, holistic approach. So with the diabetes, lipid abnormalities, which adjustment would you consider for her blood pressure? Remember, she's on amlodipine and a diuretic. She's on amlodipine and a diuretic, yeah? So would you start her on an ACE inhibitor, low-intensity statin, moderate-intensity statin, combination antihypertensive with additional cardiovascular protection, or just leave her alone? Okay? So she's going to leave your clinic today with 2 important interventions. Even though she came in asymptomatic, but she's motivated by the family history and her sister having a heart attack at a younger age, right? So you guys put the audience response, please. That's another question. Okay. Yes, that's actually a question in study design. Okay. So I don't think anyone agrees that we're going to do a low-intensity statin or a moderate-intensity statin, right? Guys, this one's wrong. So whoever's answering, just change it. Moderate-intensity statin doesn't work in any of these patients, right? Not high-risk patients, not very high-risk patients, right? 50% reduction is literally your minimum, yeah? Anybody else, you have to do more than 50% and give them a specific LDL lowering. Okay, yeah, let's get that down to 0. Otherwise, the steering committee is going to fire me if I can't get this one right. No moderate intensity statin, please. Okay, so 20 answers. Okay, yeah, make it go away. We'll stop when it goes away. I want to make this 0. Okay, fair enough. So I think we'll tackle the issue of hypertension a little bit more here. I think it was very nicely covered by Dr. Khadija, but I will show you this again. When you look at the treatment algorithm, if a patient falls into very high risk, either by screening or tests or your evaluation or by the calculation, you're going to take all of these items in the top red line, all of them, all, not optional, all. So regardless of the A1C, so if her A1C is 6.6, what are we going to do now, right? SGLT2 or GLP-1 or even both, right? Regardless, it doesn't matter. If the A1C was 5.7, would you put her on an SGLT2 inhibitor? Yes. Cardiovascular risk, same thing, right? Because she has obesity, would you put her on a GLP-1? Yes, even if the A1C was 5.7. That's the key point here, right? We're not afraid of the A1C. We use it as an entry criteria, but regardless of the other number, we have to fix it. Now, here is the glycemic control. We mentioned that. Blood pressure target and choice. So remember, there is a recommendation to get the blood pressure lower. So we have to update this because this, when we did this last year, the guidelines had not been updated for hypertension. But that's your sort of your minimum. ACE or ARB, we'll get into that in a minute. And here, remember, the wording is now high-intensity lipid-lowering therapy. It's not high-intensity statin because you need to reach less than 55, okay? High-intensity statin isn't going to get you 55. It's barely going to get you 70. You got me? Right? So wherever you start, think about this. And we've made this statement very clear. If the predicted LDL cannot be achieved with a statin, start with combination lipid-lowering agents. Start with, right? If you predict the number isn't going to fall, don't experiment. It's biology. How are you going to get it more than 50%? It's not possible, right? So think about this. This is a shift, high-intensity lipid-lowering therapy. Now, in the moderate risk, you could use a moderate-intensity statin, but this patient is by no means, right, there. And again, in terms of blood pressure target, there is a prioritization of combination blood pressure treatment, right? You really cannot be making these adjustments and expect the patient to come back and the blood pressure is still uncontrolled. Time is important and combination seems to work. It's not only for convenience and compliance, it's because of the synergy and the effect. So this patient is on a calcium channel blocker and a diuretic, right? It's a funny combination, probably because she had some edema. So she had amlodipine, a diuretic was added, didn't fix the problem, yeah? Okay, multifactorial approach. Remember, you're going to tackle all of this at the same time. We didn't talk about platelet inhibition. We will talk about in a minute. This is the blood pressure. This is the lifestyle modification, glycemic control. You have to think of these 5 things every single time a patient comes in like that, every single time. So this started with a very simple clinic visit, no reassurance, go home. Now we're tackling a lot of things, right? You see that? Use the opportunity when the patient's motivated. Now I'm going to tell you about antiplatelet therapy a little bit, and this is important. We don't talk about it a lot. There's a lot of false information about the use of aspirin or not use of aspirin, okay? So in the ASCEND study and large meta-analysis, it was shown that aspirin does reduce cardiovascular events, but it's at the cost of increased bleeding if you take a whole population. And meta-analysis showing millions of patients are getting aspirin unnecessarily. Fair enough. That doesn't mean we don't use aspirin. That's the wrong statement. In a very high-risk patient who has a low bleeding risk, aspirin is beneficial. So remember, it's not that aspirin doesn't lower the risk of stroke and heart attack. There's bleeding risk at the other side. So you don't give every diabetic patient aspirin. You don't give every low-risk patient aspirin. You have to assess the risk. So based on the woman's family history, multiple risk factors, long-standing hyperlipidemia, was probably familial, I would say she's a good candidate to get aspirin. Now, if she had peripheral artery disease, she's automatically getting aspirin. If she had calcium in her arteries, she's automatically getting aspirin, right? So if there's a cardiac indication, we get it, but I'm talking about in a patient who doesn't have peripheral artery disease. The risk can be modified and the bleeding risk is low. Now, this is actually a study called the COMPASS study. This is actually a more aggressive study. They took diabetic patients and patients with atherosclerosis and very high risk, okay? And they gave them aspirin. This is aspirin alone. Patients in aspirin alone had a 10.7% within 36 months risk of having a heart attack or a stroke. So even aspirin alone is not enough. Think about this. Now, this is a selected very high-risk group of patients, and this is where this recommendation comes from. Only in very high-risk diabetics and patients with cardiovascular disease is this indicated. Now, could we do better than aspirin alone? Yeah, if they added rivaroxaban, so Xarelto, at a low dose, it's called a vascular dose, 2.5 milligrams with aspirin, it lowered the risk almost 50% over the 3 years. However, there was an increased risk of bleeding. Again, it's a risk-benefit analysis. But at the minimum, you see that a patient on aspirin still has a 10% chance of having a heart attack. And these are patients who are well controlled with blood pressure on statins, so standard of care. So I'm just trying to highlight that aspirin is not out. You have to make a conscious decision about removing aspirin or adding it, and it's part of the guideline. Yeah? All right. So this is what's called a cardiometabolic prescription. Okay? This is a comprehensive assessment. And here's what we're going to look at. So just come back to the point about ACE and ARB. So just a very important point here. What is the most common antihypertensive being prescribed here in terms of that class? It's always ARBs for some reason, right? Why do you think that is? Is it because of mortality benefit or efficacy? It's not. It's due to a potential cough. Now, what's been registered in the Middle East and large registries is about a 3 to 7% chance a patient is going to have a cough with an ACE inhibitor, okay? So let's put the cough aside. What is the benefit of giving an ACE inhibitor? So this is a very recent meta-analysis. It actually has almost 1 million patients in the meta-analysis. ACEs, higher efficacy in reducing cardiovascular events and all-cause mortality. ACE and ARB, similar for atrial fibrillation. ACE reduces all-cause mortality and cardiovascular events, and ACEs significant reduction in mortality. So are we willing to compromise mortality and morbidity and cardiovascular events in favor of a cough that may not happen? So I know this is a reflex, right? People are now so accustomed to just giving the ARB, we don't even think about the ACE inhibitor. The ACE inhibitor is a more comprehensive blocker, right? Because it blocks upstream rather than just at the angiotensin receptor. And it has effects on bradykinin and other vascular mediators. So I think you really have to think about, you can't compromise mortality, morbidity, and evidence for a potential side effect that may not happen. Tell the patient, look, I'm going to give you an ACE inhibitor. 7% you're going to have a dry, persistent cough. It's not a cold. If it happens, come back in a month, we'll get rid of it. Okay? We can't lose a mortality advantage simply because of a possible side effect. That was like SGLT2 inhibitor. I'm not giving you an SGLT2 inhibitor because you might get a UTI. Yeah? I'm not going to give you a GLP-1 because you might get nausea. We can't think like that. We have to have evidence-based approach to the medicine. And if you look at the difference, if you look at the same meta-analysis, review ACE versus ARB for blood pressure, no difference in terms of blood pressure targeting, no difference. So if you have two medicines that do the same thing, one gives you cardiovascular outcome benefit and one does not, take the one that gives you an extra benefit, right? This is the clear advantage in mortality. So here's our new comprehensive cardiometabolic treatment regimen. So amlodipine plus the thiazide diuretic, metformin, gliclazide. This is the previous plan, right? Amlodipine with an ACE inhibitor, and it's a fixed dose combination. We removed the diuretic. Why is that? There's a conscious reason here. If amlodipine is causing the edema, right? When you add an ACE or an ARB, what happens? The edema goes away. It reduces that afferent vasodilatation, and the edema is almost certainly going to go away, right? My choice is an ACE inhibitor based on the data, which we just showed in terms of cardiovascular outcome. This is a high cardiovascular risk patient. So I need to target cardiovascular risk more effectively with an ACE rather than ARB. She can stay on metformin. Gliclazide is there. I would say that we have an opportunity here to add a GLP-1 or an SGLT2 inhibitor, right? Remember, she doesn't have proteinuria, right? She doesn't have heart failure. There's no BNP, but she's a patient with risk factors. And if she's high risk, you can use SGLT2 inhibitor or GLP-1. Very high risk, you should use either or both, right? And then in terms of the combination, again, fixed dose or single pill combinations, not just for convenience, but also for compliance and efficacy. And as I mentioned here, consider aspirin low bleeding risk, right? She doesn't have a high bleeding risk. So you conclude here is a patient who comes in for an opportunistic visit driven by her sister having a heart attack. Now you've made a lot of changes in her hypertensive regimen, in her cholesterol regimen, and also in the diabetes regimen. All right? So, questions? How do we arrive at this point? Through detailed risk assessment, right? That's the key point. The extra work that's done in risk assessment brings back tremendous rewards in terms of outcome. That's the key point. And this lady doesn't have to develop renal failure. If we get her blood pressure controlled, we put her on an ACE. She doesn't have to develop an MI if we get her LDL down, right? We could reduce an event like a stroke, which could be devastating, by adding aspirin. So all of these are evidence-based that have a direct impact on the patient, right?
For very high risk patients, instead of aspirin.
Yeah.
And in this meta-analysis, we showed aspirin or plus rivaroxaban.
Yeah.
When you consider to add rivaroxaban with aspirin?
So, if you follow the actual COMPASS study, they included patients with diabetes and very high risk, target organ damage or multiple risk factors, as well as patients with atherosclerotic cardiovascular disease. So you could do that. You could do that. If you have a patient who has diabetes and coronary artery disease, I'm always adding rivaroxaban. So somebody who's had a stent, I have a patient who has a stent. He's already on aspirin. Finished the antiplatelet therapy after the stent. Do I just stop there? No, I can add rivaroxaban. Does that make sense? So the long-term treatment now of a patient with coronary artery disease who's had a stent, you know that you're going to give them antiplatelet, aspirin long-term, and you'll add the Plavix, for example, for 3 to 6 months. After you stop that, what do? Is it sufficient or not? It's clearly not sufficient because with the aspirin, you have a 50% increase in mortality. So you can add it. It's specifically indicated in secondary prevention patients.
Yes, with secondary prevention.
Yeah.
For primary prevention, I think aspirin will be enough, right?
That's correct, yes. I'm sorry, I didn't point that out. You're right. So diabetes and ASCVD, diabetes and very high risk, right? So these are patients who, okay, to enroll in the study, you had to have had a previous cardiovascular event, either a stroke or peripheral artery disease or a coronary artery event, right? After the enrollment period, then they put these patients, and this is a big study, they have like thousands, 18,000 patients, and the diabetic subgroup seem to have the greatest benefit. So this is not diabetes on its own, it's diabetes with ASCVD, yeah?
Okay, last question. For this patient management, I think we need to change sulfonylurea to GLP-1.
Yeah, I agree, I'm sorry, should have been very clear.
Thank you, thanks.
This is a hypothetical question.
Yeah.
When you start statins, the levels will start coming down.
The-
Will we start statins
Yes.
to control the lipids?
Yeah.
The levels will come down. When we achieve the desirable levels,
Yes.
can we cut down the,
No. So this is a genetic abnormality which leads to, or a metabolic abnormality that leads to poor excretion of LDL. Remember, the diabetic patient has 2 problems, right? This patient probably has familial hyperlipidemia because the LDL is very high, 4.1. So the HMG-CoA reductase is somehow slow in its turnover of the cholesterol, right? And the LDL receptors are also not responding to the circulating LDL properly. So if you put them on the treatment, LDL responds, you remove it, it comes right back. You are continuously trying to improve the output of the LDL from the liver and the destruction into the bile. That's the process. So unlike something temporary like an antibiotic, this is a long-term commitment. And that's why it's very important to determine the target from the beginning, right? So we don't down titrate. As a matter of fact, when you look at the PCSK9 studies, so the PCSK9 like Repatha and so on, they now have an 8-year data where they looked at patients who were maintained with an LDL of 0.75. 0.75 means less than 30, actually. Over 8 years, what did these patients have? They had a 23% reduction of all-cause mortality, a 26% reduction of myocardial infarction. In the other arm, the placebo arm, of course it was higher. So lower, lower, lower for long periods of time is extremely efficient. The FDA also has looked at patients with very low LDL. So there's an analysis of patients from both ezetimibe and statin and PCSK9 statin ezetimibe. They looked at this group of patients with LDLs that are less than 1 all the way down to 0.1, which is 10 milligrams per deciliter. So in these patients, there's no increased risk of stroke, no increased risk of intracranial hemorrhage, no increased risk of gallstones, no increased risk of cancer, no increased risk of liver disease, right? But there's a 74% reduction of MI and stroke. So those patients who are very low, they're very fortunate. They also looked at this story of dementia. Patients will tell you on the social media that the cholesterol lowering lowers your brain, destroys the brain. It's incorrect. The brain produces cholesterol by what? Endogenous biosynthesis. There's a blood-brain barrier. So how did the brain survive this, right? In fact, those patients, they gave them 2,000 patients in the Ebbinghaus study. They gave them an iPad and they did a cognitive memory test. Had 140 questions for a whole year, every year. The patients who are on the lowest LDL had the highest score at the end of the year. It's reducing multi-infarct dementia, right? So you can answer the patients in that way. We're not going to stop the medication or down titrate unless there's a side effect. And number 2, long-term LDL lowering only gives you consistent risk reduction and there is no side effect of it. Thank you. Dr.
You've been talking about using high-intensity statins. Do you mind patients who are using metabolic syndromes usually have fatty liver?
Patients
who are high
Yeah,
risk usually have fatty liver and high elevated liver enzymes.
Yeah.
giving them statin would make that worse. What could we give other than
So
statins?
I think Professor Salah will talk about the NAFLD patient, but I'm going to tell you something. It's not contraindicated to give a statin to these patients. Bilaks. What you're helping is increasing hepatic turnover and hepatic clearance. So basically think about that the liver is trying to process, it's not able to, it's backing up in the liver. So the high AST and ALT are because of the fat in the liver. So we actually have, hopefully we'll get this published, with high intensity lipid lowering therapy, you see reduction of hepatic fat content using FibroScan and ultrasound. Secondly, you can tell the patient, the LFT will go up slightly, then it's going to come down. So what you're supposed to do, according to the guidelines, if your LFTs are elevated at the beginning, check after 4 weeks. If it goes up 3 times upper limit of normal, so 150, that's when you have to stop or down titrate. If not, continue. And you'll see, if you keep trending down, the LFTs will actually normalize. But this is actually one of the indicators. So what we didn't talk about is fatty liver is a risk enhancer itself for the presence of metabolic, dyslipidemia. So absolutely start the patient on a statin. Now, if you can't, then so it goes up, goes 2 times the upper limit of normal, then you have other treatments. You can give ezetimibe or PCSK9, right? But do not hesitate to give the statin in this patient. Really, it's not going to make it worse. The only way it goes up is if the patient is actually getting something else. Every patient we've seen these very high levels of LFTs, they've either received an antibiotic or somebody give them high dose paracetamol, right? Something else, or maybe surreptitious alcohol intake, so it's never really due to the statin. If you look in the statin literature, the incidence of severely elevated LFTs leading to dysfunction is extremely rare. The other one, of course, is the rhabdomyolysis. That's in 1 in 30,000 patients. It's almost unheard of, right? But it's overblown in the social media and the literature. Thank you. It's a great question. Thank you. Any other practical questions? So one thing we didn't have time to talk about today is lipoprotein A. Maybe that's going to be something else. But remember, lipoprotein A is very common in Middle Eastern and South Asian patients. We estimate it's about 26% of patients referred to our clinic. Now remember, there's a bias. It's actually a lipid clinic, so there may be a bias there. But that's high. And it's not an expensive test. It's 146 dirhams in the commercial labs. If it's elevated, it means the patient is automatically very high risk from a lipid standpoint. It means they have a genetic dyslipidemia and they have to be at a much lower level, whether they have diabetes or not. All right. Okay, thank you very much.